Hello, everybody, and welcome back to the SimKit podcast. And I am your host, Dr. Jason Hine, in my Grizzly Adams form here in our main winter. We are going to be talking about a pretty cool, kind of little, but I think an important study on a super important topic. And this is a paper related to hip fractures. So the paper itself, this is comparing the pericapsular nerve group block and fascia iliaca block for acute pain management in patients with hip fracture, a randomized clinical trial. This is by D Pietro et al. It's in Anesthesia, and this is fresh off the presses. This is December 2025. So what they do, this was a single center academic site study in Italy. It was conducted in Italy, comparing the pericapsular nerve block, or PENG block, P-E-N-G block, to the fascia iliaca block for patients with hip fractures. Now, their primary outcome was pain relief over a 60-minute interval after the block was performed. Their secondary outcomes included some pretty good ones and important ones. They looked at the number of patients who had a 33 or 50% decrease in the SPID. That is the summed pain intensity difference. So how many patients had their pain go down by 33% and 50% respectively? And of course, that's on our visual analog scale, that VAS, which goes from 0 to 10, or in here, they were actually doing 0 to 100, but it's the same scale, basically 10x. They also looked at the total amount of opioids administered in morphine milliequivalents, or MMEs, in that 60-minute time frame after the block. I wish they'd put that out a little further, but we'll get into that detail. And of course, they also looked at things like adverse events. So what were their inclusion criteria? Who did they study? Patients were included if they were 18 years of age or older in the emergency department with a radiologically confirmed proximal femur fracture. This could be subcapitate, transcervical, intertrochanteric, or peritrochanteric in nature. They had to have moderate to severe acute pain with a score of 4 or 40 at rest or with movement. That's not that high of a bar, and certainly when you add the with movement, that's a pretty good number of patients who are going to have that degree of pain. Now, they had to have capacity on their own. They had to have the capacity to provide consent and be able to do the VAS on their own, which I appreciate, right, if we think about the patient population they're studying. Patients were excluded if they had a known hypersensitivity to the anesthetic that was being used, if they had a subtrochanteric or diaphyseal or periprosthetic fracture. Of course, they were excluded there. They didn't have the right fracture morphology, if they were hemodynamically unstable, or if they had a history of severe cognitive impairment or evidence of dementia or delirium. Again, they had to be able to engage on their own, give consent on their own, and do that VAS score themselves. Now, a couple other important exclusions to keep in mind. Patients were also excluded if they had a BMI greater than 35 or if they weighed less than 40 kilograms. All right, inclusions, exclusions. They're pretty reasonable. That BMI, a little soft, but anyway, that's what they did. So study design, what did they do? How did they kind of go through their process? Patients were randomized in a 1-to-1 fashion between the two block groups, and then they were tested for pain at rest and with movement, which was hip flexion to like 15 degrees, which seems kind of terrible. It's a little bit of a torturous thing to do for a patient with a hip fracture, but they kind of had to get a baseline pain score for these patients. After they did that assessment, they were again randomized in that 1-to-1 fashion and to either the PENG block or the fascia iliaca block. Now, I thought this was pretty clever. Obviously, you can't really blind the proceduralists to the procedure, to what they're doing, but the rest of the team was blinded. Now, to maintain some of that blinding, what they did was they used local disinfectant in both of the areas where the PENG block would be done and where the fascia iliaca block would be done, so that the chlorhexidine, iodine, whatever it is covering both areas and trying to keep from the unblinding from happening, right? So the blocks themselves, they were done by a total of 6 clinicians. It's actually initially 4 emergency medicine docs, but 2 left the institution, and they had to be replaced by 2 others, so a total of 6. And they were senior emergency medicine physicians who are trained in both blocks. And as I said already, they could not be blinded to the block technique, but they completed the block and then they weren't really involved in the patient care anymore. And the treating physicians and those who were assessing the pain outcome scores, they were blinded to the block technique. Now, interestingly, all patients in both groups got 15 milligrams per kilogram of paracetamol or acetaminophen in the United States, and none were given any anxiolysis or opioids for the procedural block itself. Now, for doing the blocks, what did they do? What did they use? They used actually 0.375 levbupivacaine, 0.375 levbupivacaine, and 4 milligrams of dexamethasone. That was what they injected for these blocks. Now, for the PENG block, interestingly, all patients got 20 mLs of the levbupivacaine plus the dex, and for the fascia iliaca block, they got 30 mLs of the levbupivacaine plus dexamethasone. So after the blocks were done, patient had the pain score assessment, and they did it at 5, 15, 30, and 60-minute intervals post-block. Now, they screened 92 patients. 28 were excluded for several reasons, and that left 64, 32 in each group, because again, they were randomizing them 1-to-1. Now, interestingly and pretty importantly, there were 2 dropouts from the PENG block group. One patient was dropped out because of body habitus, which precluded their ability to actually do the technique properly, and one that had a diaphysis fracture, so should have been excluded. It was kind of a failure of randomization. So with these patients out, they decided actually to have them in their intention to treat analysis, which is good, right? They should be kept there. And they decided to score them with their SPID, that sum pain intensity difference of 0, saying basically the block didn't work. They were kept in the intention to treat for PENG, and they just said, we didn't do it. We're going to say the block didn't work. So that actually shows a potential signal for increased effect if they were included, but we'll talk about that a little bit later. All right, so results. What did they find in their results? So the PENG block group, when they looked at the randomization in the patients, the PENG block group actually had a higher pre-block VAS, visual analog score, with an average of 9 or 90 versus the fascia iliaca block group of 8 or 80. But the effects are pretty dramatic and are shown really, really well in figure 2, and we are going to reproduce that in our show notes for you. By 5 minutes, at the 5-minute mark, both groups had equal general pain at around a 7 VAS, or 70. From there, the PENG block group dropped significantly relative to the fascia iliaca block group in the pain scores as they did them at 15, 30, and 60 minutes. The PENG block group also had significantly greater summed pain intensity difference, that SPID, compared to that of the fascia iliaca block, 63% versus 38%. Now, how about that 33% drop and 50% drop? Looking at how many patients had that 33% SPID change or greater, we saw that 28 of the 32 in the PENG block group did, and 19 of the 32 in the fascia iliaca block, 28 versus 19. Now, getting down to a 50% sum pain intensity difference, 24 of the 32 in the PENG block group had that versus 7 of the 32 in the fascia iliaca block. And these differences were, as you might imagine, statistically significant. What about secondary outcomes? Rescue analgesia was given in 5 of the 30 in the PENG block group versus 10 of the 30 in the fascia iliaca block group. So it was definitely different, but not statistically so. Now, the average MME, milliequivalents of morphine, in the PENG block group was 3 versus 8 in the fascia iliaca block. So different, again, statistical power not there. All right, so what are the strengths of this paper? This is a well-executed academic study with generally good study protocols, blinding, and follow-through for these patients. It was prospective data collection with independent observers, which helps minimize bias. Doesn't eliminate it, but certainly helps. Now, while it's an academic center, it is a pretty widely applicable process, right? Doing these types of blocks to emergency medicine practitioners everywhere. So I don't hold too many qualms about that academic center. How about limitations? The thing I wanted more of was the details about the physicians performing the block and their prior experience in this. I like that they're EM docs. It's not pulling in anesthesia, which is unrealistic for most of us, but I'd love to know a little bit more about their prior experience, a little limited there. The exclusions of the BMI of 35 or higher is certainly, it's somewhat limiting, particularly in the United States with our obesity epidemic. So that restriction, not my favorite. And now they actually wanted to do this as a 2-site study, but they were unable to enroll a second site, which was going to be in the UK. So it is a single center site. So that is somewhat limiting. I would have loved to have included an additional site in the UK. Obviously, US, we'd love that stuff too. But again, back to the strengths, this procedure is performed by emergency physicians, whether it be academic or community. We all can do this. So it's generally pretty applicable, and it can be performed by most or many of us practicing emergency medicine. Now, they did have one patient excluded from the PENG block group, I said, because of anatomy and one enrollment violation. So that, tempers our enthusiasm a little bit. But if you go back to those results and see the amount of drop in each group, remember, we are looking at, they kept them in there as an intention to treat. So that denominator of 32, the changes are there despite having 2 people that were going to have no change no matter what. So we can certainly just keep these numbers at face value and still be impressed by the differences in pain scores. But it's also impressive that they were able to do that with the 2 enrollment violations or people that had to be kept in intention to treat, but actually didn't even get a PENG block. And, the last limitation I would mention is they were underpowered for that milliequivalents of morphine. And so even though there's a difference seen there, we can't say that it's statistically significant. All right, so what do we think about? What kind of discussion elements of this? Personally, I think these authors did a great job in their introduction talking about the multimodal analgesic approach to patients with these types of fractures, and generally our desire to avoid the use of opioids in frail elderly patients who tend to be the ones who break their hips. They actually cite the Royal College of Emergency Medicine best practice guideline about the use of the fascia iliaca block in emergency departments as a best practice for patients with this fracture pattern. And I think they present pretty convincing data, though relatively small numbers with 30 or 32 patients in each arm, but that it really showed the improved efficacy of the PENG block over the fascia iliaca. Now, the authors also talk about the potential benefit, though less relevant for us emergency physicians, probably more ortho, of the motor sparing effect of the quadriceps with the PENG block. So that's certainly interesting too. The authors do a really nice job of citing their own limitations, which are similar to the ones that we had mentioned. The idea of it being single-centered, and ideally we would have loved that UK site involved, et cetera, et cetera. The other thing that they mentioned, which is important to note, they had a generally short duration of observation for their anesthetic effect. They observed it up to 1 hour, 60 minutes. Now, I recognize, and the authors explain, that they did this because they wanted to prevent confounding of physical exams by consultants, patients moving onto hospital beds, and other things that might interfere with longer durations of time and things that might influence that pain over time. But 1 hour of analgesia, that's good. Seeing that effect of these blocks that we're doing for a longer duration of time and the collective MMEs used by the patients in the coming, say, 10, 12, 24 hours would be really insightful and nice to have. All right, so what are the author's conclusions? They say, and I quote, "The PENG block provides superior analgesia for the first hour after intervention when compared with the infrainguinal fascia iliaca block and represents a promising modality for acute pain management in emergency departments." What are our conclusions? Well, I tend to agree with them. I don't think that this is the most robust study that we will have comparing the PENG block and the fascia iliaca block, but it is a well-conducted study and shows a pretty dramatic effect related to pain scores and probably the MMEs of opioids given. I personally don't need a more robust study comparing these two approaches. And yes, I am in full agreement that regional anesthesia should be standard practice for elderly patients with hip fractures. I myself have been a fascia iliaca block person for the entirety of my career, but I have recently moved to doing some of these pain blocks, and with this study, this may be my preferred location for elderly patients with hip fractures. Of course, we need to keep in mind body habitus, the fact that this is a above the inguinal ligament approach. We have to consider that in patients that have anticoagulated state, etc. But when both the fascia iliaca block and PENG block are an options for the patients I'm caring for, I'm going to be reaching for PENG. So I hope that was interesting and insightful for you. We have a reference to the article itself. Again, take a look at that figure 2, which really shows that dramatic difference. And for those who subscribe to SimKit, know that we have a robust regional anesthesia library for you available. It includes the PENG block, fascia iliaca block, and many, many others. So if you're interested in learning these techniques, consider signing up or check out that resource library where we have all of these blocks to do. Thanks for listening.